It's a delight to see you all, and I'm here on behalf of the School of Commenting and also the organization that John and Peter are with, which is the Christian Justice
Council. Christian Council for Monetary Justice and the Coalition for Economic Justice, the two bodies.
I can never pronounce that, so thank you. And thank you all for coming. I have a deep interest in dedicating the seminars this week to the memory of Eleanor Ostrom, who first encapsulated a lot of these ideas of the commons from the 1960s until her passing just this past summer. And I had the honor of meeting her once, as well as her husband, Vincent Ostrom, who was an equally profound scholar in the area of the commons. And we miss her, and her last project, as Anna had mentioned, was the health commons. She had discovered at the end of her life that the health commons was the next frontier that she wanted to explore. So it's very interesting now that we're picking up the thread and we're moving it forward. I think this conversation has a lot of interest, and I think that this group is giving voice to something new, even though you can still find the modalities of health commons here and there on the internet. Nobody's really put it together in a comprehensive way, and I really believe that this is a new wave that's going to become extremely well known and a kind of no-brainer. People 15, 20 years from now will say, well, why weren't they thinking that back in the 1960s and 70s and 80s? Why did it take so long to realize the kinds of ideas about sustainable health that we're discussing here today? So I think a big reason for that is, it goes back to historically, for a few centuries now, we have been divided in many ways, not only socially but also cognitively, beginning with the ideas of John Locke, our eminent English philosopher who was also a political scientist. He began to make arguments like, just as the mind owns the body, so a person owns property, kind of combining metaphysics with political science and making a grave error along the way by saying that the mind owns the body. The mind certainly doesn't own the body. But that cachet has resonated with us even down through Freud and many others who have kind of posited the relationship between the conscious and unconscious. And if you look at that, it means mind and body, or the division between the head and the heart, in a sense. This has a lot to say about healthcare, because if we are stuck in our heads and we have one kind of frame of reference about what medical care really means, then it's easy for us to outsource our interest into the hospitals and into the modalities of healthcare professionals, and not realize that through the intersubjectivity of our bodies, we already have a community that can give us wonderful advice on the remedies or the kinds of ways that we need for healing. This has another aspect to it, which is that over this period of time that we've had this mind-body split, it's also replicated itself in a split between producers and consumers. And if we model the wholeness of our lives from the society that we have now, with this division of labor between producers and consumers, what that results in is a reification of the mind-body split. So no wonder we have lost the thread of the health commons over the centuries, because of the very fact that we have not had a philosophy of integration that's been promoting healthcare, nor has it been promoting integration in society. In the present economic system, the market creates value by enclosing a common area. That could be land or natural or mineral resources. But these enclosures also have been applied to culture and ideas in digital space. Now, through this process of enclosure, the division of labor between producers and consumers creates a top-down hierarchical structure in the flow of private and public goods. This is said to increase economic efficiency and productivity and quality while lowering the costs of goods and services. That's the rationale that we hear all the time. But current business models based on the division of labor are becoming less and less useful. Evolutionary forms today of technology and culture are altering the nature of resource exchange systems and creating new ways of interacting and coordinating social and economic life. We are now in the midst of a transition from hierarchical governance and institutional forms to ones which are based upon decentralization and peer-to-peer interaction. Interactive and innovative models and tools are emerging that are now enabling us to organize and coordinate our activity in new ways. They're transforming the nature of community and social institutions. New norms and rules are being developed to oversee collective resources sustainability that involve peer-to-peer management and open source models. And we know that these innovative systems are emerging, certainly through the technology that we're using. That includes the software and the open hardware groups, open media and educational models, open collaborative research in commerce and science, and even greater degree of horizontal decision-making in our communities. Technologically, we're watching the Linux programs and we're watching Wikipedia. These are non-hierarchical models which don't depend on centralized quality control, but the collective goodwill of community. This is deeply influencing us, but it's not at random, because this is an evolutionary wave that's taking hold all over the world. It's being driven by technology, but it's also an evolutionary impulse, I think. What's unique is that the greater good is achieved by individuals working collectively on a voluntary basis out of conscious choice, not out of dependency on coercion or that would be generated by a central authority. This is one of the points that's stressed by Eleanor and Vincent Ostrom over and over again, that the Commons model really developed out of their understanding of what was happening not only in the digital community, but also in traditional communities, indigenous communities. They've been following open source models for centuries, even though they had no technology. They knew open source intuitively. So the convergence of the new technology and the old models is creating new illumination for society now, and we're giving voice to it. The health commons that we're discussing today is clearly giving voice to this. Now, when resource users become the co-producers of their own resources, their motivations and knowledge and skills become part of the production praxis. And this leads to new ways of coordinating social and economic life and the development of innovative property management structures. And this expands the distribution of the means of production and decision-making far more widely than through top-down systems. When consumers become co-producers of the goods and services that they receive and organize, their mutual activity transcends privatization, centralization, and the idea that institutional change can come only through a traditional command structure or social hierarchy. With the proliferation of these innovative platforms and models that are more and more collaborative, communities are now engaging around projects in a deeper and more powerful way. This technology is emerging at the same time that government provisioning of public services under the 20th century social welfare model is breaking down. Not only are people discovering these new systems, that they're demanding greater choice and quality in public services, and they're seeking to provide the services themselves where possible. The Commons movement is demonstrating how technology, culture, and evolutionary forces are driving resource users to become the producers of their own resources. And the emerging commons society points the way toward new political accountability structures, which reflect less command and control delivery of public services and more subsidiarity, pluralism, and polycentricity in the provisioning of people's needs. It's not just co-production that we need, it's also co-governance. We've now begun to understand how commons principles apply to healthcare, shifting the discourse and practice from cure and disease to behavior and well-being. In healthcare, as in other social modalities where people cannot always provide their own technical specialized services, the goal is to close the gap between resource users and resource providers. Whereas in the present hierarchy of the healthcare system, the emphasis is on prolonging life, but not on improving quality of life and relationship. In the emerging healthcare system, as we are seeing it, private and public purchasers, healthcare organizations, clinicians, and patients will be working together to redesign healthcare processes. There's a long developmental stage, I think, through this that we could discuss, but I'm going to skip over a bit of it. It has to do with generating personal awareness, then moving to the stage of creating vibrant relationships and accountability between us, and then moving further toward a process of direct participation in our communities to achieve these health modalities. And here is where awareness and relationship and accountability lead directly to participation and provide a greater sense of empowerment. When people become health advocates, they take their knowledge and practice into the workplace and neighborhoods and engage and inspire others in sustainable health practices. Through participation, individuals experience a degree of control and become better able to define and analyze their concerns and find joint solutions to act on their own issues. People can be equipped with the knowledge and confidence and skills to make a difference in their communities. Participation then leads to empowerment. And it's really empowerment that's the key, because the research has been for years indicating that personal empowerment has a tremendous impact on human health and well-being of individuals and communities. Empowerment is about allowing people to take control of the decisions that influence their lives. You can't give empowerment to people, but you can create the conditions by which individuals and communities can empower themselves. This means groups of people working to enrich their own lives and to acquire skills and advocate for their own kinds of change. Community empowerment involves power relations and intervention strategies which ultimately focus on challenging social injustice through political and social processes. This starts with, as I said, personal awareness, and goes through the cohesion of small mutual groups, and then community organizations and partnerships, and then groups of people taking political and social action to create social change through the redistribution of resources and power. And again, it's co-production, but it's also co-governance. Because what's needed is new accountability structures where producers and users of health resources are one and the same people to the extent that's possible. Rather than outsourcing responsibility for public services to government or to corporations, which creates a top-down service delivery structure, these new accountability structures will allow communities to guarantee and manage health care for their members. Communities can form their own health trusts. This would ensure that resource users are driving the health process, not resource providers or managers. This means the communities are going to have to organize in new ways. But creating these new kinds of political accountability structures through social charters and health trusts would enable communities to obtain quality health care services on their own terms. And it would lead to improved quality of services, a reduction of the institutional barriers of governments, enhancing participation in local government, strengthening civil society associations, and creating healthy public policies which lead to improved health. There are many things that we could talk about today, and I'm sure we will. New networks for information and education, along many different lines, creating a clearinghouse of best practices and education on, and workshops and seminars on health literacy and health as a common good, and how to develop commons-friendly practices. We could talk about particular information which is valuable at the community level on obesity, heart disease, diabetes, depression, which are all linked to food, which don't require medical care from hospitals. We could talk about information on healthy eating and physical fitness activities and mental health and health inequalities, which can be done in the community. We can talk about links with groups which foster sustainable therapies like exercise and yoga and plants and herbs and diets and breathing exercises, and living medicine organizations that teach healthcare and the use of food for better health. All of these things are possible. Community medicinal gardens that are used as part of self-care. The need for greater evidence-based decision-making that's derived from the best available scientific knowledge. Need for greater transparency so that information to patients and their families allows them to make informed decisions. Social networks for patient data, peer-to-peer disease management in the communities, and patient-doctor medical pacts for continuous responsive healing relationships, not just in the clinical setting, but over the internet, by telephone, and by other means in addition to face-to-face visits. We could talk about the new groups of healthcare organizations to increase quality, including civil society and the commons and local health boards and city agencies. So, as Anna said earlier, I think a new story is emerging, a new kind of awareness of what it means to have a health commons, what it means to call personal health a commons. It's very important that we engage in that conversation. And I look forward to our discussion today as we develop this new narrative. Thank you very much.